Now, the launch and implementation of the Social Health Authority by the Kenya Kwanza government is Kenya's strategy towards attaining universal health coverage for the fourth time. Despite teething problems that have pushed many Kenyans to the wall and in some instances paying out of pocket, many Kenyans still do not have an understanding of this new model and what to expect from it. And we sat down with the State Department of Medical Services Principal Secretary at the Ministry of Health, Harry Kimtai, to highlight key strategies that will steer this health plan.
2 months since the implementation of the Social Health Insurance Fund under the Social Health Authority, and the country is still trying to get its grounding. Kenyans are expected to contribute 2.75% of their monthly contributions, with an outpatient capitation at 900 Kenya shillings, down from 1,200 Kenya shillings under the defunct NHIF. But how exactly is this money going to be utilized?
The contributions where we pay 900 is basically the capitation fee that we pay to the facilities, and these facilities are categorized. They're categorized into 2 levels, which is level 2 and level 3. How they are supposed to offer service is based on the capitation, the number of population that visit that facility times the 900 shillings that they are supposed to pay. And then that is remitted to them on a quarterly basis. So they are supposed to treat the patients free, because level 2 and level 3, it is free primary health care services that we offer at those levels. So this, we assume, will be able to suffice for those levels. We also did open this to level 4 because we realized that some of the populations where the level 2 and level 3 are is a bit far. So we elected some of the level 4s to also offer such kind of services where it is capitated. So that's on capitation. So we believe that is sufficient enough because it is dealing with the minor ailments.
There have been several challenges that have been highlighted under the Social Health Authority. Was this system rushed?
No, it's not been rushed. We just faced challenges. We realized there was no proper legal framework. Because we're using the old. The way NHIF was delivering, and you want to deliver social health, universal health care, it was impossible. With the challenges of NHIF in itself, it's impossible. Collections, when we tried raising the collections through the NHIF Act, FKE, went to court. Stopped that. I said, okay, so what do we do? I said, okay, let's start afresh. So we developed a legal framework that provided for 3 acts. The Primary Healthcare Act, the Digital Health Act, the Facility Improvement Act, and the Social Health Insurance Act. 4. Each with specific functionalities.
Then again, how much has the Social Health Authority collected since its implementation in October?
For the first month, we collected about 6.4 billion. The second month, it slightly dropped to about, I think it's about 5.3 billion Kenya shillings. We also want to encourage Kenyans to pay. Maybe they paid the first month. They have not paid their second month. All right, because we told them pay monthly for the time being. You know, we want those who are unemployed to pay the entire amount upfront. But again, we faced, there was a lot of hue and cry. Kenyans are saying, why do you want me to pay everything at a go? So we've opened up for them for a period of, we agreed for a period of 3 or 4 months, as we develop what's called the insurance premium financing.
How much does the Social Health Authority owe facilities in claims?
2.1 billion. Yeah, of which we have paid. The second month was another, I think they're telling me they have paid 1.1 billion. Clauses, the transition clauses provided for Social Health Authority taking over the liabilities and assets of NHIF. So we had to do an estimate how much is due and whatever. That's why you get this 29, about 30 billion Kenya shillings. So what is being processed through the NHIF system, I've told you, as of 4th of October, was 19 billion.
The Ministry of Health announced that it will review the Social Health Authority tariffs. But why is this the case?
We are not reviewing benefits every quarter. We are saying these benefits, it's yearly benefits. Mark you, there's inflation and change, innovation, all right? So we also have to be responsive to the market. So we can't have that forever. The cost of drugs are either going up, and therefore we don't want the patients also. As you pay, all right? As you pay, you should have commensurate. All right, there should be some where we look at if all of us have paid, all right, and the cost of this service is being procured at this much. And I can tell you, I'll only cover up to 50 or 60%. So the 40%, you say you have to go back to your pocket, isn't it? So we want to review this. Either some are too high, all right, or others are too low.
During an interview with NTV, former Deputy President Rigathi Gachagua mentioned that the 104 billion Safaricom has used to implement this new system could have costed the taxpayer way less. From where you sit, because you're in the front lines of this implementation, is this indeed the case?
No, the person then who was carrying out the interview would not have asked why now and not that time.
Experts have told me that it was possible to improve the existing system that was in NHIF at a cost of between 7 to 800 million. Here we are spending over 100 billion. And from where I sit, when I look at the whole rush of this SHA shifting, it is because of this 104 billion. That is where the issue is.
When I give you a figure, 104 billion, you might ask yourself, wow, this is a lot of money. But then you do costing of what is it supposed to do is when you realize it might be less. Because we are supposed to do so much. But we will work within now the budget that we've agreed so that we're able to achieve much. So in terms of the scope, we believe there's value for money.
With that being said, Safaricom has also contracted another local company called Savannah to implement the digital health system.
Why did we pick Safaricom? Because of the wide network, and Safaricom being a national, one of our listed companies that has shown that they are able to deliver where technology is required. Now, Safaricom cannot do everything alone. They have partners. They have to bring in consortium members. So we could not put a lot of, say, micro, I can call it micro or mini, right? We had to have, say, this is the scope.
What of instances where a Kenyan would be under-declaring their income and cheating the system?
So if you are cheating the system, it's okay. What you're telling you make your declaration, all right? We also not just leaving you there, we shall be doing your assessment. We shall continuously also reviewing your assessment. Because we want every Kenyan to pay an average price that you know based on your income.
And for the employed?
The responsibility is vested on your employer. Those we follow, we do audits on the employer payroll and know exactly how much are your employees, how much are you paying your employees, and how much are you supposed to deduct from your employees. In the event that such an employer does not remit the deductions, then the law makes a provisions for penalties to the employee for not or deducting and not remitting to Social Health Authority.
How will teenage mothers be able to get services under the Social Health Authority and even under Linda Mama?
As a ministry, we came up with a policy to guide that, and we have guided Social Health Authority to allow now registration as a teenage mother, and then they are because they are now in the Linda Mama program, so it's not a big challenge to us. They will pay for them as teenage mothers. So we've opened that. The fact that they have gone to the facility for antenatal, they are able to be identified.
Kenyans have raised concerns over data protection, especially with the new digital health system. Can you assure Kenyans that their data will be protected?
The Ministry and State Department for Medical Services followed the requirements of the data protection laws. We complied. We did an impact assessment, and we submitted the reports to Office of the Data Protection, and we were given the acceptance to proceed with implementation because the data of Kenyans is protected in accordance to the Data Protection Act.
Clinical officers have been on the streets condemning the Social Health Authority Board Chair Dr. Abdi Mohammed of discriminating them.
We have more than 1,000 facilities that have been registered by the Clinical Officers Council. We have over 5,000 specialized clinical officers. These people, under the NHIF, they were offering services to Kenyans. But now the SHA board has decided only those registered by the KMPDC can be registered and contracted or can do pre-authorization.
Clinical officer, including specialist clinical officer, are now forced to go through an individual who are registered under the KMPDC.
I'm not seeing the challenge between SHA and the Clinical Officers Council and unions. We said we are streamlining the healthcare system. We are reorganizing the healthcare system. We looked at how do we onboard facilities. First step, we said, okay, fine. The regulator that has a wider mandate is the Kenya Medical and Dentist Practitioners Council, which is supposed to inspect every facility and license and categorize that license, that facility. It is KMPDC. We don't deny what the provisions of the Clinical Council, the Council Act also says in terms of who is the Clinical Council, what Clinical Council can do. We're not refusing. It is there, it is provided for in the law. They can license you as a clinical officer, that's a requirement. And also, when you declare that I want to operate from here, they can also license that facility or that premise or that room for you to offer that service. That's okay. But the wider mandate goes back to the KMPDC. Mark you, even before, it was the NHIF who were visiting these places. They have licensed the place, but NHIF will again visit and go and file a report and panel and then come on contract before. So we said, okay, no, it can't be like this. Let's give it the regulators. So we want to make sure that when we do an audit trail, who did what? We have had cases where we have lost patients just because of negligence here, negligence there, who did what. The problem is, them, they said, no, why you are favoring doctor? We are not favoring anybody.
Helen Aura, NTV.
All right, and that